Yeah, thank you, Chairperson and my friends, and also my co-faculties, Dr. V.T. Shah and Dr. O.P. Yadav. Both are our very good friends, guide and philosopher. What I'm going to do for the next 10 minutes, since we are already 1 hour delay, is to talk about how to rethink of use of aspirin for primary prevention of coronary artery disease. Why this particular topic is important? Because there are benefits and there are harms. So let us see, do the benefit outweighs the harms? And that is a question. And that's what we are going to discuss for the next 8 to 10 minutes on that. What are the possible benefits of aspirin? Why we should think of using aspirin? Because to prevent myocardial infarction. If you see this particular slide, if you give aspirin and say here you don't give aspirin, and when you study 1,000 patients over 10 years, and the difference between the patient who is receiving and not receiving is hardly any difference. That means 2.7 and 2.2%. That means when you treat 1,000 patients over 10 years, avoiding the MI, if patient is receiving aspirin and not receiving is not significant. This is all in patients who are in the low risk category. Now, these are the various evidences what we have. All-cause mortality or cardiovascular mortality, there is no impact or a very small reduction of using aspirin is a high-quality evidence is available. Non-fatal MI, likely a reduction in non-fatal MI over 10 years. This is a moderate quality evidence. And a non-fatal stroke, we have likely no reduction or a very small reduction in the non-fatal stroke over 10 years, again a moderate quality evidence. Colonic cancer incidence over 10 years follow-up has shown a possible reduction, a low quality evidence. Possibly that is the only area where the primary prevention of aspirin may be possible. So if you look into all these various evidences, the benefits of using low-dose aspirin is not available on the evidence. On the other side, what are the potential risks we have? If you see in 2009, all the meta-analysis of the 6 primary prevention trial, using aspirin, there is a 54% increased risk of major bleeding in the GI tract and the other extracranial. If you see the relative risk is 1.54 as against the placebo. More or less similar data in 2016 meta-analysis, same dose using aspirin less than 100 milligram versus the placebo, same GI tract bleeding and the other, like extracranial bleeding. Now, in 2019 meta-analysis, which includes some of the recent trial like Ascent, Arrive, and the Aspirin trial, have again showed that the low-dose aspirin is, produces, intracranial hemorrhage as compared to the placebo, and also the greatest risk for subdural and extradural hemorrhage. So, if you have to see all these, the meta-analysis, 2009 hazard ratio 1.54. If you look at 2016, 1.58. If you look at 2019, 1.53. So all the meta-analysis suggests there is a potential risk. Now, if you see the US Preventive Services Task Force identified the increasing age, male sex, and the diabetes are the possible causes of increased risk of major bleeding when you are using aspirin in a primary prevention. Therefore, we have to look into these 3 main, the factors which are accounting for increased bleeding. Ascent trial is one where diabetes patients have been studied and almost 15,000 plus patients, and it was seen again the difference between the risk of death of, between the placebo and the aspirin 9.7 versus 10.2. So if you see the hazard ratio 0.94, over a median follow-up of 7.4 years, which is again, statistically not significant. Error trial is one wherein, the moderate CVD risk patient, 12,000 plus patient, and the follow-up is almost 5 years. The difference between the placebo and the aspirin arm is 2.55 and 2.57, again suggesting the Error trial has not shown positivity of using aspirin. If you see the Aspirin trial, wherein people beyond age of 70 years, almost 90,000 plus patient, again a follow-up of 4.7 years study, and it was clearly shown the risk of death from any cause 12.7 with aspirin and 11 without aspirin, again suggesting Again, hazard ratio 1.14. So all these three, Ascend, Arrive, and the Aspirin trials are favoring not to use that. Now let us see patient without the prior CVD, how to use aspirin if at all. Low risk individual, there is no benefit at all. If you see here again, the benefit or the risk in low risk individual is not statistically significant. In an intermediate risk patient also, if you look at 10-year follow-up, it will reduce 17 MIs, but 16 more extracranial bleeding. So what we call is a net benefit, because it does reduce MI, at the same time increases 16 more extracranial bleeding. So net benefit is not favoring. So the recommendation is individual patient values and preferences. And whereas in a high risk individual, particularly a patient who got a high risk of cardiovascular disease, those with 10-year risk of more than 20%, or people 40 years with a multiple comorbidity, or people with a familial hypercholesterolemia, and this is the group where probably the benefit of long-term daily aspirin is favorable, but still the absolute benefit remains small and potential risk present. So possibly if you are to go by this particular the characterization, high risk individual in these 2-3 kind of situation, we can make a possibility. What does the AHA ACC 2019 guideline tells us? 2B class of recommendation, level of evidence is A. Low dose aspirin might be considered for the primary prevention of atherosclerotic cardiovascular disease among select adults between 40 to 70 who are at high risk of atherosclerotic cardiovascular disease risk, but not at increased bleeding. This is the most important thing. And the harm in both the thing should not be administered on a routine basis for the primary prevention beyond 70 years and people with the increased bleeding. So two important things what the AHA mentions: beyond age of 70 and increased risk of bleeding, we should not be using aspirin. So what does the recommendation of the AHA, ACC and the US Preventive Service Task Force? Again, the low risk is recommended only between the age of 50 to 59 who have a 10-year risk of more than 10% and who have a life expectancy more than 10 years, and they are willing to take aspirin, and the risk, of course, is calculated according to the AHA, ACC cardiovascular risk. However, evidence to recommend aspirin in a population age 60 to 69 is less robust, and beyond 70 years, we should not be giving because there is inefficient evidence. And therefore, again, US Preventive Task Force also is matching with the 2019 ACC-AHA. Let us look at the European Society guideline, and this is particularly in a diabetic patient. What are the indication? Class 2B and level of evidence is A. Low dose aspirin is considered for the primary prevention in the absence of clear contraindication. That means patient with the diabetes at a moderate CV, here, this is one, with the diabetes at high or a very high risk, but no increased bleeding or no increase other contraindication. Whereas patient who have got moderate risk is not recommended, it's harmful. Gastric protection, of course, the proton pump inhibitor recommended whenever you are using aspirin. 2A level of evidence is A to prevent the GI bleed, etc. What the dosing and anything particular, this is the study where it's shown almost more than 2 lakh patients, systematic review, 31 studies. They have clearly shown 200 milligram and above increases the major bleeding, and between the 100 and 200 milligram, non-major bleeding. So the risk of using less than 100, as against the risk of using aspirin more than 100 is significant. So again, the benefit and the risk is favoring a small dose of 75 to 100 milligram. So let us look at what is the practical approach to low dose aspirin for a primary prevention. Here, assessment of the patient's baseline level of understanding, patient activation to engage in discussion. In the sample question, what is asked here, very, very important. We must remember whenever we want to give low dose aspirin for a primary prevention, patient engagement is very, very important. We should discuss the review of potential benefit and the harms very clearly. What are the benefits? CVD mortality reduction, reduced myocardial infarction, reduced stroke, reduced colorectal cancer. Harms are intracranial bleeding, major and minor, GI bleeding, bruising, increased cause follow-up visit, etc. And the third, most importantly, assessment of patient preference with a sample question, all the detail about whether he understands why we are giving, and why he's looking into the positive benefit, etc. So coming to the last slide, and that is my the take home message. Now, how to recommend practical approach to low dose aspirin for a primary prevention. When patient is not under current treatment of low dose aspirin, then consider initiation when you got a high cardiovascular disease risk more than 15%, high colorectal cancer, which we are not discussing today. But this is one area that has been recommended that it is useful. And then the low bleeding risk are the important 3 indications where patient not on undercurrent treatment, low dose aspirin is recommended. Discuss benefit and the harms between 7.5 to 15%, 10-year intermediate CV risk. We have to discuss with the patient family. Avoid initiation if it's a low CVD risk, less than 7.5, and the high bleeding risk. So there is no place for using aspirin here. Now, for example, patient is already receiving low dose aspirin for a primary prevention, whether you are going to continue the treatment. That is, again, consider continuation, almost more or less the same thing. That means the high cardiovascular disease risk, high colorectal cancer risk, longer duration of past aspirin is
1 minute left.
Already is using more than 10 years. Discuss the benefit and harms in an intermediate risk. Consider discontinuation if the patient is having low cardiovascular disease risk that is less than 7.5%, 10 years, shorter duration of past aspirin is less than 5 years, high bleeding risk. So it's a very clear cut, the approach how to use the low dose aspirin. Thank you very much. Thank you, Dr. Mahapatra and Dr. Manoria for giving.
Thank you, Dr. Sadanand Shetty, for your very good, excellent talk on this aspirin. And now, actually, the new guidelines have recommended aspirin use in primary prevention for people 40 to 70.
Yeah.
And older who are at higher risk for the first cardiovascular event. That is also there.